Okay, hello everyone, and welcome to another conversation on our channel, Shoulder Evidence into Practice. Today we're going to discuss frozen shoulder. Are we missing the bigger picture? Current evidence, clinical rationing, and future direction. We are Germana and Larissa. We're both physiotherapists with PhD, as well as professor and researcher. And in Brazil, we're specializing in shoulder rehabilitation. So today, we're delighted to welcome two special guests. First of all, Fabrizio, thank you very much for accepting our invitation. I also welcome Pablo and thanking him for joining the discussion. So, Larry, thank you. Before we get started, would either you like to say a few words? Or I also like to each one to present because I think it's better. For example, Fabrizio and Pablo say something about our work, and I think it's better than I present here. And if you want to start, let's go.
Yeah. Hi, Germana and Larissa, and it's a very pleasure for me to be here, to be invited here. Also because there is my great friend Pablo, so it's a very good idea to meet all together. I am a clinician and a researcher, and I'm really focused on shoulder disorders, and in particular on frozen shoulder from a clinician and research perspective. And I live in Lecce, where I work as a clinician, and I teach and work as a researcher in University of Molise. And so my work is divided. I love to stay with patients. I like to work with patients to communicate and to have experiences with patients that transform and increase my ideas for research. So it's a very good dimension from my side to be both a clinician and researcher. So.
Okay, thank you, Fabrizio. Pablo, please.
Hey guys, thank you so much for having me. I appreciate your invitation, the possibility of talking about frozen shoulder. That is one thing that we love to discuss. We love to interact about this condition. It's a real pleasure to be here, sharing with Fabri, that is he's a key opinion leader about frozen shoulder in the world. We love their research. So I really appreciate your invitation. Like Fabri, my situation is very similar. I am a clinician and researcher as well. My focus is in shoulder disease. I've been working with this condition since 2011, and the past year I finished my PhD. That my line in research was frozen shoulder as well. So for me to be again have the possibility to be here and discussing about frozen shoulder, it's a real pleasure. Thank you again to having me.
Very nice. And I would like to say it's a pleasure to me be with all you three, because I know that I'm learning a lot with you three. And before I start, and Germano start, I'd like to say a phrase in Italian, but a bad Italian. Grazie per aver accettato il nostro invito.
Whoa, really good, Larry.
Very good. Your Italian is not so bad, don't worry.
Probably to say more better Italian than us.
Okay, Larry, over to you for the first question. Let's get started.
Perfect. Fabrizio, now in Brazil, when we do our physical therapy school, we learn that the phrase of Codman in 1934, like frozen shoulders, hard to explain, hard to define, hard to treat. And I'd like to ask you, how can you define or how can you explain frozen shoulder today? It is just a shoulder problem, or we talk about a lot of things.
Thank you, Larissa. This is a very good question. When I started, to teach us to my students, I often cite this sentence from Kodman because it's real. It's very difficult to treat. Frozen shoulder is difficult to treat, and we know it because we know that the path of care is very long. So we are not sure if our exercises, our manual therapy, our stretching is the best choice. We are not sure if the corticosteroid injection is a multi-sites or intraarticular or bi-oral. We don't know so well how is the best approach. So it's very difficult to treat. And it's also very difficult to explain because we started from a peripheral pathologies, a structural, biomedical, structural-centered pathology that is into the shoulder. And we are going to understand that maybe is a musculoskeletal epiphenomenon from a systemic imbalance. So we are going in a really different perspective. So it's also very difficult to explain. We however, now in 2026 we know much more than Kodman ever did because we have a good knowledge about the inflammatory path and the shift from inflammatory to fibrotic path into the frozen shoulder development. But maybe we don't understand the entire square, the entire picture. We know the role of macrophages. We know the role about fibroblasty. We know the myofibroblasty. So we know so much. But in my opinion, there are also some dark sides of in the path. So maybe Kodman is still the Kodman sentence is still real, but in a different perspective because we know much more. We know much more, but not the whole the score.
Fabrizio, in Brazil, we commonly use the term adhesive capsulitis.
Yeah.
So why shouldn't? Yes, why shouldn't clinicians use that term, for example? Why do you think about it?
I think that frozen shoulder is the up to date, the optimal term because frozen shoulder greatly describe the person's feelings of subject suffering from frozen shoulder. Adhesive capsulitis up to date is a mislabel, is a misnaming, because capsulitis is itis for the suffix explain also the first path of the pathology, so the inflammatory path, and it does not describe the fibrotic evolution of the last stages. And also because adhesive capsulitis, the word adhesive is not real, because many authors start to search about the adhesion from capsule to the humeral head, and they doesn't find such adhesion. Only one study found the adhesion like a bar spot on the humeral head on 6 spacemen of the shoulders. So many other authors that looked for this adhesion didn't find it. So maybe this word could also increase in the clinician the idea to perform some techniques that want to detach the adhesion. And this is not real, because if you perform, as an example, a manipulation under anesthesia, you can detach the adherents, but you broke the capsule. So the label is very important, because increase an expectation from patient, for example. So I want you to detach my adherents because I want to move fastly, okay, to recover fastly. So the expectation of the patient should be real and not modulated by a wrong label. So maybe the label is very important. And also the scientific associations, such as ISACOS, for example, suggest to keep the frozen shoulder as the main label, and to don't use adhesive capsulitis, because it's a wrong word that does not describe the real path of the pathology.
Yeah, it's very interesting the point that Fabri discussed, and it's very interesting the heterogeneity that we have about the health community in the world. Just for example, the other day, I received a review, and the recommendation was change frozen shoulder to capsulitis.
Yeah.
And obviously my answer was no, and I had an explanation about why. But it's interesting about, well, I really agree with Fabri about no more capsulitis. Is a terrible label, specifically about that. This is a nocivo label. It sounds a bad thing for the patient and the expectation and the possible consequences. It's more interesting discussing about frozen shoulder, stiff shoulder, and it's interesting about the point that Fabri said about, for example, the ISACOS Society in comparison with the American Society, discussing about, a stiff shoulder or primary frozen shoulder or secondary frozen shoulder, or talking about just frozen shoulder to the primary frozen shoulder, and I'm talking about a stiff shoulder to the secondary frozen shoulder. This is a really interesting discussion about, sometimes, because we know that that's very different, the primary condition in comparison to the secondary condition. But the problem that we have now is the heterogeneity about the opinions in the world about the terms of capsulitis or frozen shoulder. The rehabilitation community, we agree, we are together talking about frozen shoulder. But the problem, in my opinion, I think that is physicians or other community.
Yeah, perfectly agree. And also the real interesting discussion is about the primary or secondary frozen shoulder or stiff shoulder. For example, in the ITOI classification, they divided the frozen shoulder from secondary stiff shoulder. I'm not fully in full agreement with this, because secondary frozen shoulder, how can I say, let you to understand that is caused by a pathology, a known pathology, a concurrent pathology. As an example, a frozen shoulder that developed after the rotator cuff repair. So you can say that is a secondary frozen shoulder. In my opinion, if the frozen shoulder is caused by the rotator cuff repair, you will have all patients with rotator cuff repair with frozen shoulder, because the cause-effect connection is always real, is always present. In my opinion, the only thing that we surely don't know about frozen shoulder is the trigger. What is the trigger of frozen shoulder? Also in the primary frozen shoulder, we don't know the trigger. We know the inflammatory pathway, we know the alarmin, we know the transforming growth factor, and so on, but we don't know the trigger. So in my opinion, that rotator cuff repair, the proximal humeral head fracture, or for example, the surgery to the hand that requires immobilization from 3 weeks, for example, are a recognizable trigger. In that case, in the idiopathic frozen shoulder, you have the trigger, but probably we don't know about it, so we can't recognize it. So I proposed the two weeks ago, if I remember, a classification with frozen shoulder with hypothesized concurrent pathology, the secondary one, or frozen shoulder without an hypothesized or without a link with a concurrent pathology, because it's the same label. In the two difference is that you know or you don't know, you hypothesize or you don't hypothesize a concurrent pathology linked with frozen shoulder. The systemic subclassification from Zuckerberg and all may be not so real, because systemic is a background where the frozen shoulder, where the diabetes, where the major depression, where the cardiovascular pathologies grow up. So it's a background that predispose frozen shoulder. So when you recognize a pathology, a concurrent pathology, you recognize the trigger. But maybe the trigger is always present, but we can't recognize it sometimes. So we speak about the primary frozen shoulder. But maybe it must be a trigger.
Yeah, really agree.
It must be a trigger.
Yeah.
So
Yeah.
and this is also because you have a second frozen shoulder on the opposite shoulder, often in patients that get a primary frozen shoulder in one shoulder. So why? Because there is an underground, there is a humus, there is a background that increase the probability that frozen shoulder develop. Okay, this is my thought.
Interesting point. Yeah, really interesting point. I think we can talk more about the interaction between among the factors. And we can say that there are a lot of associated factors to start maybe the frozen shoulder. Yeah. Maybe I think we can talk about the etiology of this condition. And I know in your background, some researchers that you developed are focused on metabolic and neuroendocrine factors. And I want to know more about this. What do you think about these factors in the interaction in the body of a person to develop the frozen shoulder? I just want to know what is your thoughts about it.
I would say the frozen shoulder for me is an epiphenomenon, a musculoskeletal epiphenomenon of systemic dysregulation. So, in my opinion, metabolic path matters. I'm also thinking to study the microbiome, or the intestinal microbiome, because the intestinal microbiome is the major reserve of bacteric and of lipopolysaccharides that when overcome the intestinal blood barriers, increase the systemic inflammation of the body. And this is also increased by high lipopolysaccharides rich diet, for example, and the higher BMI, for example, and adipose tissues increase the prevalence and the incidence of frozen shoulder. And also glucose, so the hyperglycemia, also into the normal range. If you have the normal range, 80, 100, the normal range of glycemia, you have more prevalence to develop frozen shoulder for patients that have from 90 to 100 glycemia than the people that have from 80 to 90 glycemia. So also in normal ranges, you can have an increase of prevalence. And also for pre-diabetic patients, it's not only the diabetes, but also in pre-diabetes patients, you have an increased possibility to develop frozen shoulder. So for me, metabolic and most of all, the glycemic profile is really, really important. Mm-hmm. And the ages, the advanced glycation products are really close related with the availability of glucose and increase the stiffness of the joint, of the capsule. So we know that the important role of the ages in the etiopathogenesis and in the development of frozen shoulder. The ages increase the inflammation through NF cape belt procytokine, inflammatory procytokine, and also increase the transforming growth factor role. And they link and they modulate the shape of the collagen, changing the property of collagen. And also they occupies the binding site of metalloproteinases and obstacles the metalloproteinases to degrade the collagen. So the central law of the ages and on the glucose and the glycemia is a really, really important role. So in my opinion, the metabolic path really matters in this pathology.
Fabri, this is really interesting. And when you see, for example, a patient, a frozen shoulder patient with diabetes, and you see, for example, some outcome measures, you see the impact of the diabetes, specifically in range of motion. Are you agree about this point? Because, well, I remember, for example, treating patients, diabetic patient with frozen shoulder, and I remember they started with negative degree of range of motion, and I remember that the evolution is very long in comparison with other frozen shoulder profile, and this connecting very good with the part that you said down. So are you agree about this point?
Yeah, perfectly agree, because in one study of Michel Mertens of 2022, we know that thyroid dysregulation and diabetes and autonomic dysfunction are negative prognostic factors for the quality of life and the range of motion recovery. So I perfectly agree with your clinical impression, and also in my clinical activities, I see that diabetic patients have a slow recovery and also a worse recovery instead of patients without diabetes. Probably for the role of the glucose and the role of the ages in the etiopathogenesis of frozen shoulder. Because if you have more availability of glucose, maybe more ages you can produce. There are 88 sites where in the collagen molecule where the ages can develop and can alter the collagen shape. So there are many sites that transformation of the protein. So maybe absolutely yes, the diabetes is a very worst prognostic factor for recovery.
One of the worst phenotypes
maybe.
Amazing point, and this reinforce our role as health educators with these people.
Yeah, in my clinical practice, I always ask in the first interview about the health status, the comorbidity, and so on. And when patients say that when I treat only shoulder disorders patients with shoulder disorders, not so hip, knee, neck, nothing.
I totally understand you.
Nothing, because I have some colleagues and I refer the patients to them. But when patients tell me I have a shoulder pain, okay, how many times from your last blood analysis? It's very important, because if you suspect that the patient could have a frozen shoulder, and you know that there is a close relation between frozen shoulder and, for example, altered glucose metabolism, it's our role as health professional to promote health and to say, keep attention, stay attention, because this pathology is closely related with altered metabolism of glucose. Maybe you can stay in pre-diabetes, so it's useful for your global health to manage this state before it comes to diabetes. Or it's very good to increase your activity level, for example, post-lunch activity level, to decrease the glycemic level, for example. So our role is not only to treat patients with pathology and so on, but also to promote a general state of health, because I win where patients can treat themselves, increasing their health status, increasing their activity level, eat well, sleep well, and so on. This is my win as a health profession.
Yes.
Yeah.
Good message.
Yeah. We have to educate the patient with to this health style.
Absolutely.
Okay. Yeah. I agree.
I think, Larry?
No,
I will start to talk about diagnosis. So I don't know if you have another question.
I have a question because I know beyond this biological mechanism, you work, your researcher also places a strong emphasis in the patient's lived experience, and how do psychological and social, especially social factors, fit into current understanding of frozen shoulder?
When we thought to conduct the systematic review that you're referring for, systematic review of qualitative studies about the experience of patients living with frozen shoulder, we have the suspect that biological is okay, psychological, yes, we know, but we have suspect that also social networking have a strong importance in this. And our research confirmed our suspect, because effectively patients need to be supported, and sometimes frozen shoulder is not recognized in its powerful impact on their lives. So often the patients around, the people around the patients don't recognize this impact, and the patient is mistrust, is frustrated because subject does not give the importance to the pathology, because the patients come to work, because the patients stay in this laptop, but lacks concentration, for example, because of the sleepless nights. So the work is not good. They did not perform how they have, and often subjects can see a pathology, because frozen shoulder for a sedentary worker is not so important, no, you can say, but and so the social networking often is a problem for the patient, and also the health professional, because sometimes we extract some results that show us that also the health professional are not, how can I say, they are very superficial in asking about pain. They asking also about pain and range of motion restriction, but they doesn't ask about the role into the family, because the patient lost his role into the family, because they can't cooking for all family, they can't dress the daughters, they can't drive, for example, for bring the daughters to the school, and so on. They lost the role, the family role, and also the work role, and they also role the self-esteem, because I am the center of the family, because I manage my daughters, my child, my husband, and so on. And then I need my husband to take my jacket, because I don't have the internal rotation for reach it. So the patient always lost something. There is not only the range of motion. So we understand this, deeply understand this by these studies, this qualitative research, because qualitative research tends to increase the awareness of the feeling of the patient. It is a very field of research that, in my opinion, should go in parallel with the quantitative one, because there are two dimensions that give you the complete picture of the pathology.
Fabri, and this is very interesting about the quality studies, and this is very interesting about the quality view of this kind of patient. And we know that, for example, talking about psychosocial factors in frozen shoulder, we know a lot about depression. Well, your studies are amazing, connecting these outcomes with this pathology. But this is even very stressing about, for example, the quality interviews and the answer of the patients. My question is specifically connecting the quality studies with the trigger. How is your experience about the past stories, the past history of the patients, specifically? Let me give you an example, because, for example, in my first interview with the frozen shoulder patients, I tried to know how was the past story. Well, I've been listening terrible stories, specifically about just son dies, loss of work, terrible.
The pandemic.
Yeah. It's a very good point, Pablo. It's a very good point, because we don't give so much importance to this, but in my opinion, is a very good point. There are some evidence in literature, not contextualized in frozen shoulder, but in musculoskeletal disease, that tell us that a continuous, great, deep path, social path, as an example, abuse, as an example, abuse during childhood, as an example, social rejecting, so bullyism, so to be a victim of bullying. So this kind of situation could alert a transcriptional conservative advance to an ancient, an ancient neuroimmunological path that alerted you when you go to have a prey to eat in the ancient, and we have now when we think to a threat. If I have always under a threat because I am abused, because I am rejected, because I'm out of friends, without friends, and so on, my systemic level of inflammation increase, because there are always cytokines and interleukin and also products of fibrosis inside with higher level inside my body, in systemic level, and this is a known cause of major depression. But major depression is one of the comorbidities that are associated to frozen shoulder, such as diabetes, and diabetes always rise on the same background. So my personal idea is that prolonged and very bad events, prolonged events, could be a cause of develop of frozen shoulder, as the same that could be a cause of develop of some systemic pathologies. Okay, so this is my thought. I don't have proof of this, but there are proofs that perpetuating and continuous social events, most of all social trauma, social events, could increase the systemic level of chronic low-grade inflammation. And we know that chronic low-grade inflammation is a background on which frozen shoulder developed, with all the other pathologies that are seen as comorbidity associated, but they are not associated. In my opinion, they grow from the same background. They are not associated one with the other, but they grow in the same background. So the systemic epiphenomenon of this is diabetic. The musculoskeletal epiphenomenon of this is frozen shoulder. The brain phenomenon is depression, major depression. And the vascular phenomenon is cardiovasculopathy. So because of this, is very important our role as educator to manage some bad habits that increase low-grade inflammation, the role of other professionals such as psychologists to manage the reaction, our reaction to the situation that we could have during the life. So this is my opinion that I am happy to share with you because you asked so. But I think that is a very good field of research in the future.
Well, I mean, you're giving us an amazing example of complexity reasoning based in the biopsychosocial model and no a biomedical system that is very, very linear, but just thinking in one cause. So your example is amazing.
Yeah, it's a very good studying the conservative transcriptional response to adversity. That is the ancient neuroimmunological system that we have during the prehistoric life, and the actual consequence that could have the reiterant, the activation of this is very interesting to I read some article about it, and I think about frozen shoulder in my study, my private practice that I manage with exercise and manual therapy, and so this decrease my ability with manual with hands and increase my my thought about what could be the cause of a pathology, an expression that we treat with our hands, and maybe also without to educate, without speaking so much, when it could be the opposite, maybe.
Very nice. There's a beauty in this discussion, because I remember when I read an article about the perceived injustice. There is a connection with a higher levels of pain. So someone who perceives, who have injustice in his life, it's connected, it's linked with higher levels of pain. So there's reinforced the importance of the context of these people, and we need to be attention. We need to be like how can I say I forgot the name, but the escutativa. How can
Yes, it's active listening.
Yes, perfect. The importance of the active listening to understand these other context factors. And talking a little bit about diagnosis, we already discussed with our group about the challenge of the early stage of frozen shoulder. when you receive someone in this stage, Fabrizio, how do you know, how can you recognize, oh, I receive a patient with frozen shoulder in my front?
It's a very
Fabrizio, to frozen shoulder, to image or not to image?
Yeah. No, it's a very good point, because we often see the patient with the arm close to the chest. So in a later stage of frozen shoulder, with the arm with a very several range of motion restriction, and this is a problem, a real problem for the quality of life of the patient, because the disability is so high. So the best should be to have a early stage awareness of this pathology. But it's challenging, because the early stage frozen shoulder is quite similar, is sometimes equal, in my opinion, to rotator cuff related shoulder pain. So you have a pain, maybe end range pain, but no range of motion restriction, but it's okay, but I can do this and that. So the clinician starts, for example, with his therapeutic path, with the exercises. And the worst things, and the clinician starts with the educational path about tendinopathy. There is the opposite for to the frozen shoulder one. And when after 3-4 weeks you see the range of motion that is really limiting, you have to change your educational path and your prognosis, and there is a great decrease of adherence between the clinician and the patient. So it's a rare problem. In my opinion, we have to think that every painful shoulder should be suspected to become a frozen shoulder. Every painful shoulder, and we have to target our anamnesis, our medical history questionnaire interview about some indexes, some variables that could increase the indexes of suspicion that painful shoulder should evolve in a painful, less stiff shoulder. Some variables could increase our suspicion. For example, some predisposing factor during the interview. We know that female sex is a predisposing factors, and also the age is from 40 to 65 is a recognized predisposing factor. We know that glucose metabolism is interesting for predisposing factors. So diabetes, pre-diabetes, glycemia level, hypertriglyceridism, and also sedentary is a predisposing factor. Also, it's not so strong, but also the non-dominant harm could be a weak predisposing factor. So we have a strong predisposing factor recognized with the evidence, sex and age and diabetic or glycemia, and the weak predisposing factor, and we have to weight them in our clinical reasoning. Then we could deeper investigate with the coracoid pain test. Coracoid pain test was constructed by Carbone, a Roman orthopedist, and for distinguish the pain elicited at the coracoid process from the pain elicited at the anterolateral acromial border and also to the AC joint, and a score of 2 points between one side on the others could further increase your index of suspicion, because the coracohumeral ligament, that is a key feature of the frozen shoulder, originates from the coracoid. So a higher coracoid pain could be suspect to in the frozen shoulder. And also 2 years ago, I think, Michel Mertens increased the methodological robustness of the test, adding an algometer instead of the manual pressure, and also adding two modalities to perform the test, for a side-by-side comparison and for the intensity of pain modality. So not only is the comparison between the coracoid and the other two sides, but also the higher pain level in the shoulder, and also the comparison side by side. And this is a further index for a further variable to increase the index of suspicion. Also, the correct measurement of the range of motion should be a variable, an interesting variable, because in the early stage of frozen shoulder, the shoulder didn't have range of motion restriction. But if you measure with an inclinometer, for example, you can be more sensible to an early loss of range of motion. So it's not so the patients have not to lose 30 degrees, 40 degrees, but also if in 3 weeks you can detect a small loss of active and passive range of motion, you can raise your suspicion of early stage frozen shoulder. So is another variable interesting. And also the use of ultrasound. The ultrasound could detect some mimicking pathologies, for example, a bursitis, for example, a massive rotator cuff tear, but also could increase the index of suspicion of the early stage frozen shoulder, because could detect some interesting variables into the ultrasound image that they could be indicative. For example, the halo sign. The halo sign is an area, hypoechoic or anechoic area around the long end of biceps tendon that could indicate the capsular involvement. And also the hyperexpression of vascular path into the rotator interval. That could be interesting, because the first phase of frozen shoulder is about a hyperexpression of inflammatory path into the rotator interval. So it could be if you compare the one shoulder with another, it could be informative of, for example, an early stage frozen shoulder. But there are, to be honest, there are preliminary evidence, because we have to admit that research is not so strong in this field. So we are so many variables that could be indicative of an early stage frozen shoulder, but we have to think about it and we have to weight it with them in our clinical reasoning. So it's not to found a halo sign is not sure that you have a frozen shoulder, early stage frozen shoulder in front of you. If you see if you don't see some hyperexpression of vascular parameters into the rotator interval, you could not be sure that this is not a frozen shoulder. So we have many variables, and we must weight it into our reasoning So from demographic, clinical, imaging, we have many variables that could increase our clinical suspicion, but we should suspect it because we are sure that the patients have a rotator cuff or rotator shoulder pain. We don't suspect that it could be a frozen shoulder at early stage, at its beginning. So our mind should be open. It should be open to have at present diagnosis, but also to the changing of the clinical path. And we have to reason again and say, oh, it's another variable, loss of range of motion. Okay, it could be a rotator cuff related shoulder pain more painful because algogenic restriction of motion, okay, but it also passive restriction of motion. So maybe not, maybe the starting point of fibrosis that follow the inflammation phase. So we have to also to evaluate the clinical picture day by day. And the changing of clinical picture often are more informative than the first day interview. Okay, so in my opinion, the early stage frozen shoulder is challenging, yeah, but we have a lot of variables that we can evaluate, we can assess, and we can weight in our clinical reasoning. And maybe if we understand that we remember some variables, we can avoid that frozen shoulder reach its higher impact, its higher disability for patients. So it's very, very good perform that clinician can do for our patients.
Yeah, really good point. So I'm curious about this, specifically the early phase, because I know you published a paper about the inflammatory phase and the ultrasound. I think Philip Strupp was in this manuscript, I remember. Do you think physiotherapy has a role during this early phase, or just in the treatment, for example, just corticosteroid? What do you think about it? Because the inflammatory phase is followed by fibrotic process, metabolic, inflammatory. You know, I don't know.
I perfectly understand. It's a very good point. If we think that the physiotherapist is only to hands-off path, maybe in this phase is not so good, because maybe you can higher the inflammatory path, because myofibroblasts, there are the molecular that synthesize vimentin. There is a contractile protein that narrow the capsule around the humeral head, are chemiosensible to transforming growth factor, to interleukin and so on, but also mechanosensible to the lot. So if you are aggressive in mobilization, you can paradoxically worsen the situation. But physiotherapy is not only hands-on approach. Physiotherapy is also education to the path. Physiotherapy is also reassurance that the prognosis is benign. Physiotherapy is also education about, for example, they try to improve your sleep habits, and that we know that the sleep path and a good lowering the chronic inflammation to the body, the systemic inflammation to the body, for example. Physiotherapy is also education to lifestyle, to manage the post-lunch glycemic with physical activity, for example. So in my opinion, in the first phase, in the inflammatory phase of frozen shoulder, I don't like to speak about the first phase, two phase, and the third phase. And the inflammatory phase, in the inflammatory period of frozen shoulder, we are very, very important to take care of the patients. Not to take the hands-on, but to take care of the patients, to educate, to inform, to orient his behavioral path, and also to avoid that the maladaptive beliefs increase, the catastrophizing increase, the fear avoidance behavior increase. So we are really, really important, close to inflammatory path, anti-inflammatory path, to the corticosteroids, to the orthopedics, so the physiatrics, pharmacological management. In Italy, we can't administer drugs. So I don't know in Brazil, but in Italy, the patient with frozen shoulder is managed by the physiotherapist and by the doctor that provide to the anti-inflammatory path. So, in my opinion, physiotherapy is really important also in the first stage, in the early stage, but with a particularly educational approach and informative approach, and not with the hands-on approach or the exercise approach. In my private practice, I always educate and inform my patients and give always active exercise, active assisted exercise, no manual therapy in the first stage from my side. And then when the pain is settled, then I start to gently mobilize, and I always refer to the clinical path of patients when I want to administer manual therapy. Okay.
I think the Fabry message, especially at this first stage, is very important, because in the clinical practice, it's very common to see a patient that maybe he received 5 sessions with another 5 physiotherapists before our first session. And my question is, why? Well, because this is for a lack of information, the message was not good, and the expectation was without control. So this first stage, our message is very, very important. I really agree with Fabri.
Or they insert a lot of force against the movement and increase the pain of the patient. It's a kind of crazy things that I saw and I listened around.
Because someone want to unlock the arm.
Yes, I listened.
We have to unlock your arm. What?
Mm-hmm.
Yeah. It's terrible. It's a nightmare for the patients.
Yeah. And about the another stages, what is the points that is a kind of clinical decision making? Oh, I do this. Oh, I need to do this. How do you approach the patients with a stiffness shoulder?
In my clinical path, I try to follow how much is possible the evidences. So I treat these patients with exercise, manual therapy, stretching, and home exercise. This is the receipt. Obviously, my clinical path is tailored to the patient that I have in front, that is in front of me. As an example, the quote of manual therapy or exercise are modulated as the irritability level of patients. And in a high irritability, I prefer to have low manual therapy and much more exercises. And in the low irritability, high stiffness patients, I prefer to give insights of manual therapy and stretching, and the exercise is at home, for example. And it's also is dependent also for the compliance of the patients, because some patients is not so compliant to have home exercise. So educational path is not only for the first phase, but also for all the path. We have to go straight with the importance of the exposure of the stimulating the shoulder with the stretching or with the exercise for improve the clinical situation. So I prefer to work at end range, because some weak evidence from Kubuk, I don't know, 2023, if I will remember, results that end range mobilization is more beneficial than middle range mobilization, and some evidence tell us that anterior to posterior mobilization could be more beneficial than other direction. So I prefer to work anterior to posterior. A good point is painful mobilization or non-painful mobilization. In my opinion, with patients with frozen shoulder, we can't have a non-painful mobilization, because often patients are always pain. So distraction, glide, slide is always painful. So a painless mobilization or a not painful mobilization is impossible, often impossible in my clinical practice. I believe that educate the patient that a tolerable mobilization, a bearable mobilization could be beneficial, could be proficient for the rehabilitation, takes me the opportunity to have an informed and collaborative patients, and not a patient that I have on my practice bed and I start to mobilize without educating, without informing. So the very important is to engage the patients, explain the patients, and give some stimulation that is bearable for the patients. And so we can work with manual therapy in a proficient manner.
Fabri, just for curiosity, how is the situation in Italy about the health of the surgeon treatment? Because you know the UK first trial about the three arms, about what arm was the physiotherapist treatment, and the another was manipulation under anesthetic, and another was a capsular release. How is the current situation in Italy about that? Is the first treatment always is physiotherapy for, well, physiotherapy? We say physiotherapy that we know that is a physio treatment with a lot of things, you know.
Yeah.
But how is the situation? Because here, for example, I try to explain to the patient about the three possibilities, but it's not common the surgery, and it's not common I don't, yeah, my recommendation is not good about the manipulation under anesthetic, but the possible consequences. So how is the current situation in Italy?
Current situation in Italy is that physiotherapy is seen as the best choice. Physiotherapist and corticosteroid injection is seen as the best choice for the majority of surgeons and physiotherapists. Maybe the possibility for non-responders, there are very few people, about 2% of all people that I know, is arthrolysis arthroscopy. Manipulation under anesthesia is practiced by few surgeons and few people, and in my opinion, there is a more proficient alternative, such as arthrolysis, because you have to strongly profile your patient before to administer manipulation anesthesia, because the adverse events could be interesting. could be okay. So, for example, rotator cuff turn, for example, fracture, for example, many other things. And when I know that the Rangan 2020 trial, so the UK first trial, tell me that it's equal at 1 year, I always try to suggest to go to a shoulder surgeon, to expert shoulder surgeon for arthrolysis. I contact the surgeon and so on, obviously, but personally, I don't suggest manipulation of anesthesia, because I think that arthrolysis is a very detailed, a very controlled detachment, and very controlled work from an expert surgeon that could be more beneficial for patients without adverse events, or without so much adverse events.
Yeah, perfect. So
about the Rangan, just a quick comment, but I still thinking about this study, because, for example, when some people receive manipulation under anesthesia, after this, these people will do physical therapy treatment. So maybe sometimes we compare physical therapy with physical therapy too. So
yeah,
it's a kind of discussion of this.
And it's the same with the capsular release. And the question of all patients is, okay, if I choose just, for example, a capsular release, how is the path? That's the same about the recovery. It's the same time. And to be honest, I don't have the answer, because I don't have clinical experience about that. I've not been reading some papers with good evidence about that. So it's a difficult question.
Yeah, for sure.
yeah.
And just another another comment. I don't know in Italy and also in Argentina, but in Brazil, sometimes we receive some patients who have a quickly improvement. And it's a challenge to manage this, like a sense of urgency. I don't know if you pass through these two.
Often the expectation after the manipulation of anesthesia or also after the electrolysis are not realistic sometimes, because people expect to unlock his shoulder from 1 minute to the other. So they had to face with higher pain after the procedures, after both the procedures, have to face off with edema, with the arm that doesn't move quite the same as before. So also the expectation should be modulated for this treatment and not only for physiotherapy.
Yeah. Fab, I have a question about the treatment, because in Brazil and of course Italy and Argentina, maybe we use a lot of electrophysical agents. And how do you see the role of these agents in patients with frozen shoulder?
I think that in the best rehabilitation path for frozen shoulder, there is not space, not chance for electrophysical agents now, because there are few evidence supporting the use, because the clinical threshold are rarely overcome of the effect, and because also the higher rate of prices to use these agents. So in my opinion, we have some most useful weapons for in our hands, and if I well remember, the only electrophysical agents that has some evidence supporting its use is extracorporeal shockwave therapy. But is a very painful approach, and maybe it is not a very good idea for high irritability patients. And also the clinical effect is not so high also for an early or midterm effect. So in my opinion, we have to increase the study of these electrophysical agents about the clinical effect and not only the in-lab effect. So the clinical effect matters, and also the clinical threshold matters, and not only the statistical significance. And then we can sustain the use, we can support its use, not before.
Yeah, I agree. So this has been a really interesting conversation, but I know I could stay here talking all day.
All the day.
Yeah, all the day, yeah. So I'm just moving to the final of this conversation and looking, I want to know about Pablo and Fabrizio and of course Lari, looking ahead 5 to 10 years, how do you see the management of frozen shoulder challenging us our understanding toward a more systemic and psychosocial model? How do you see in a long term, for example?
I hope that frozen shoulder will be recognized as a multi-systemic and a multi-domain pathology, and people with frozen shoulder will be taken care by a multi-domain, a network of health professionals. That the patient will be profiled in a metabolic path, psychological path, and physical path, and so on. And the key driver of the clinical presentation should be targeted by the ad hoc professional. This is a dream, I know, but I hope that in the future the patient will be take into consideration from this perspective, the multi-domain perspective, a inter-professional perspective, because it's not the multi-professional the answer, but the inter-professional. When professional speak each other about the patients, as sometimes happened with, for example, with a patient with a fracture. So the surgeon speak with the vascular surgeon, the orthopedist, and also the other with the nurse, with the technician in the surgery room, and so on. And all together they decide the path. Okay, this is a very will be the ideal taking care, because we know that frozen shoulder is a multi-dimensional pathology. So the idea is that multi-professional should be included in the therapeutic path. So this is the future that I see, and I will work to this reconnaissance of the pathology in its multidimensional dimensions. Pablo, what do you think about?
I really agree with you. I really agree with you in all your points, talking about the try to think that frozen shoulder is not just for a physiotherapist. We need to work each other with other health professionals. My dream is may higher the physio level about frozen shoulder, because sometimes linking with the example that I said before, sometimes I saw patient that's this history about the past physio treatment is not good, And I mean, may higher the physio level is one of my dream. I would like to contribute to that, in my country and all the region and in the world for the next year. But I'm sure that the situation going to be better maybe in 10 years or no. I would like to say again to you, your studies are really good, are very good. I love to read that. And especially for the connection between the research and the clinical practice that, sometimes it's not an easy job. It's not that easy to read, some kind of research, and you are doing a very, very good job about frozen shoulder. And without doubt, like I said you before, you are the capo cagnonieri for the frozen shoulder. Without doubt.
Thank you, my friend. Thank you, my friend.
Yeah. So, Lari, do you want to say something?
No, I just want to thank you. Thank you, Fabrizio. Thank you, Pablo too, Germana too. Fabrizio, thank you for sharing your knowledge. I learned a lot today, and I'm very sure that the people who watching us then later will learn a lot with you too. So congratulations for your part in your field, and move on, keep working, and you will increase in growth together as a professional. So thank you.
Thank you for your invitation. It was a very pleasure to be with you. It was a pleasure to share my knowledge, to discuss about frozen shoulder. Is my mission, my mission for my practice and my research. So it's a very pleasure for me. Thank you.
Yeah, it was an inspiring discussion, Fabrizio and Pablo. Thank you very much for your time, and I hope next in the next time we can discuss more about the news of the frozen shoulder. Yeah.
Stay tuned.
Thank you.
And I would love to see you in person. I will love that.
Yeah, of course. Okay, guys, thank you, and thank you all that are watching in this video now or before, and thank you very much. Bye.
Big night from Italy.
Bye.
Thank you, guys. Bye. See you.
Bye.
We